So I'm the last one who will be talking. I was asked to talk about Europe, but that's hard for somebody who's from Europe because Europe is not a country. There are many countries there, and they all do it differently. For example, in France, I know that they have divided vascular and non-vascular types of EDS. That's a little bit also in the UK. You're not Europe anymore, but they still count you as. And I know that Ghent does it a little bit, so Belgium does it a little bit like us in the Netherlands. And the question is, how do I access the care I need? So I can talk about this from a Dutch perspective, so from the Netherlands, and how the system itself works. So the healthcare system is that there's a three-line principle. In many countries you have that, I think. And at the bottom of this three lines is the general practitioner. Not the bottom, actually, the top. Because they are the ones where you go to if you have complaints. That's where you start as a patient. Any complaints, you go to the GP. And to be honest, we're expecting a lot of our GPs, right? Because they have to know a little bit about everything. And if we're looking at musculoskeletal problems, we're looking at them a lot. We really want them to be able to help patients within their own community, let's say, or their own neighborhoods to be helped so that they don't have to go to like second and third line care. So what we're doing right now is trying to get a better understanding to our GPs about what is hypermobility and when is it pathological and which lines do you have to follow. Can you stay within, for example, the first line with the physiotherapist and other allied health carers, or do you need to go to second line, a rheumatologist, like my colleague, Dr. Kaskas, for example, and what type of rheumatologist? Can you stay in the second line, or do you have to go to the third line? So these are things that are important to keep the system moving, but also to get the people care. Finally, you want to get the correct care also to the correct people. So if you only have sorry for that word, but if you have musculoskeletal problems that can be dealt with without going to second or third line, this is what we prefer because you're helping the person in question, and also they don't get into that whole system. And I think most of you know how it is to be in that system. But there are people you cannot help just with the first line, because as we also know, it's not just musculoskeletal problems, it's a multisystemic disease, and some people have way more than that. Now, I think our center, we're an expertise center, plays an important role in getting the knowledge out there about what the disease is. And of course, internationally, we do this together with the EDS Society. Nationally, we do it together with our patient organizations, and in Europe, which in a broader context we do within the European reference networks, which are funded by the European Union. To get the information across is important. So first of all, those who need more help than just that third line, they need to move on to the second line, the rheumatologist. And then there are also people who need to go one step further to the third line, where you have the medical specialists who work in teaching hospitals, so academic hospitals. For example, in Holland, the only geneticists, geneticists only work in teaching hospitals. By law, we are not allowed to work outside of academia. You can imagine if there are only academic centers who can do genetic testing, there are not a lot of geneticists. And also, if you realize that a lot of geneticists are needed for every type of genetic disease, you can also understand why not every center has 2, 3, or 4 people just looking at connective tissue disorders. So we have been quite strict in who we think should be referred to us or not. Not because we think people don't have a right to see a geneticist. It's because of you need to get the right care to the right person. And to be able to do that with the amount of people we have to be strict. But then you're also afraid, and that's a question we get a lot, aren't we missing diagnoses, etc.? But I think Dr. Lekautis today with her results showed very well that we can do this quite well, find who needs genetic tests and who does not. And in that way, I think our system works. Can it be better? Sure, definitely. And I think the most important thing that can be better is that we get those second-line doctors to understand why it's so important that they do their work. Because there are many who do their work very well, don't misunderstand me. But I think, as you said, it's quite an accomplishment to get those videos out there on the rheumatology, National Rheumatology side. Yeah. So we're working on that. We're trying to get that better. We have one expertise center for all the EDSs in the Netherlands. That's in Rotterdam. That's the one I coordinate. But we have 2 more for vascular types of EDS. One in Nijmegen and one in Utrecht. And yeah, so that's how the system works. Is there anything else that I wanted to tell you? Yeah, and I think, as I said, we have this expertise center, we have a multidisciplinary team, but we do find that EDS is not a single disease. It's heterogeneous. You've heard that a lot, I think, but they really are 13 different diseases. So what we find is that we have very little numbers of, for example, the rarer types. And for this reason, the expertise we have is usually, if you stay within the Netherlands, only based on now maximum of 20 people. And in order to get the right expertise also to the very rarer diseases, what you need to do is have the international collaborations. So we also do a lot of research, and we try to do that not just in the Netherlands, but working together, either via the EDS Society, either via our own contacts, or via the European reference networks. Thank you.